everybody who has zoomed in to join us in BPD Awareness Week to hear about some of the current research in the personality disorder field. We have four presentations in the next 90 minutes and they're quite varied, so there's a lot of interesting content today. There is a Q&A option at the bottom of your screen. So we'd like, if you have questions or you'd like clarification or to share any information, if you type it into the Q&A during the presentations, and then we should have about 5 minutes at the end of each where we can go through the questions and give the presenters an opportunity to respond. So I'll start by welcoming Dr. Daniel Ring, who's here and waiting and ready to go. And Daniel's provided a bio, which I'll just use briefly to introduce him. So he's a junior doctor and he's zooming in today from Adelaide, lucky him. And he works in the local health network there. And he's previously published in the area of stigma and BPD under the guidance of Professor Sharon Lawn. And I have found your papers, and it's always nice to see Australian publications that are so useful and worthwhile in the BPD field. So he has developed an interest in mental health and education, and when lockdown ends, he's looking forward to going dancing with friends. And I hope if you haven't had your wish already, that you get that very soon, Daniel. Thank you very much for joining us today.
Thank you, Jill. And let me see if I can share my content. All right, can everybody see that? And can everybody hear? I just wanted to start by acknowledging the traditional owners of the land that I'm currently on, the Kaurna people, and to pay my respects to elders, both past, present, and emerging. I'm also just now realizing that this is a national conference and there's people coming in from all parts of the country. So thank you all for joining us today. I'm not feeling too nervous. I'm kidding, I'm feeling very nervous. So my article is based around my research that I did as a medical student in stigma around BPD. And I did this with Professor Sharon Lawn, who is an absolute pioneer and genius in the area. And it initially came about because as part of my degree, there was a research component and I was interested in mental health broadly. But I also noticed that BPD was quite interesting in that certainly mental health, as we all know, experiences a degree of stigma, but BPD in particular experiences stigma simply just within healthcare and not so much as broadly within the kind of mainstream public. So I was kind of curious about what that stigma looked like and what was the impact and the effect of that. So this is the definition of borderline personality disorder from the DSM-5. And we're probably all familiar that in order to reach the diagnostic criteria, you need to have 5 out of the 8 criterions. But what I've noticed from my limited experience as a junior doctor is actually that BPD exists on a spectrum. And it's not the case that everybody with BPD is the same. And even though it's described as a personality disorder, really it's quite an individual condition, and the way it manifests for different people is very different. So although somebody can have a diagnosis of BPD, what that means for one particular person is really based on their individual lived experience. So I think it's very important from a clinician perspective to take that on board and to really realize that there's such a diversity within one simple condition. Nevertheless, it's still a condition, regardless of what a person experiences, that has a lot of stigma attached to it. When I was initially preparing to do my research, I came across an article by Professor Lawn, actually, with this particular statistic here, in that when a person with BPD is accessing mainstream healthcare, especially during a time of crisis, the primary concern which gives them the most anxiety is the idea that they won't be taken seriously in a healthcare setting. And so just the idea that somebody at their most vulnerable, when they're most in need of help, is very concerned with the fact that they just won't be taken seriously was appalling. And the fact that it's 71.3% of the people within that demographic was astounding. So I was like, okay, we know that there's such a stigma within healthcare around BPD. We've known that for a while, but why hasn't there been any attempts to change that? And besides just the kind of experience between a worker and a client, what are the ramifications of that? I guess in terms of how people can access services and the things that eventuate from that. So that kind of formed our research questions for the paper, and we really wanted to have some evidence to kind of back this up and to really form out what the whole experience looked like. So when we did a literature review, which kind of looked at the papers which addressed stigma directly, and a lot of papers, although they addressed stigma directly, didn't provide any empirical evidence. They kind of provided theoretical models and some explanations, but nobody was giving us the evidence to back up what we already knew. We managed to find 30 papers from the last 50 or 60 years, which actually provided the evidence to really formulate some kind of structure in order to explain what the stigma looked like. And it was a mixture of qualitative and quantitative experiences. So from those 30 papers, we were able to distill the information into about 6 different themes, which had a good overlap over each other. And I might go through these themes very quickly if you'd be willing to listen to me hear them out. So the first is this idea that BPD is not a treatable illness, which BPD is a treatable illness, and there's some very good treatments for it available. But because there's this idea within healthcare that somebody with BPD is untreatable when they come into an acute healthcare setting, the clinician feels like, oh, there's nothing I can do. I'm just going to have to send this person away. Secondly, the idea that BPD is untreatable means that in a community setting, when people are being referred to psychiatrists and some psychologists, historically, there's some evidence to suggest that actually clinicians have refused to see people with BPD simply because they don't think, again, that they can offer anything for them in regards to treatment. And so that leads to an overall impact in that there are less services, specific specialist services that are able to be provided for people with BPD. And as a result, there's kind of queues for treatment and a lot of delays in people getting the help they need, the targeted help they needed quickly. I know that DBT is the gold standard for BPD, and I know in Adelaide we've got some really good DBT programs, but again, especially this year during COVID, the DBT programs were full. They weren't accepting any new clients to the programs. There was only existing clients. And so I think people with new diagnoses of BPD had to look for alternative psychotherapies. I know there's a lot of practitioners doing transference-based psychotherapy and some schema therapy, which is also very good and very effective for some people. But it is a shame that the DBT programs are full and that we can't actually meet the service load for the demographic that we have within Adelaide. So as part of that perceived untreatability, the stigma response, especially from the healthcare worker perspective, comes about from feeling this sense of powerlessness, that as a clinician, if you don't think that you can offer anything for the client coming through, but there's this expectation that you're the clinician, you should be able to do something in the situation and you should be able to help, it threatens your role as a clinician. And it makes you feel powerless. So instead of feeling that vulnerability and that powerlessness, you can then flip that idea onto the person that's presenting. So this person is coming into this setting and they have a condition I can't treat. So it's their fault for presenting for the condition I can't treat, rather than saying to yourself, oh, this is an area for me to go out, educate myself and come back on, so I'm better able to provide the treatment there. And it's been that way for a while, in that BPD wasn't well understood, and it was often the case that blame was attributed to the client because it was assumed that people had agency over their illness and were choosing to act in the way that they were when they were encountering healthcare settings, which, as most of us know, is not the case at all. It's very much a symptom of an illness. So in that way, clinicians kind of took that sense of powerlessness and then converted it into a stigmatized experience, putting the blame back onto the clients coming through. Because of that kind of stigmatized experience, and because of the fact that it's been built over about 50 years or so, with that same kind of perpetuating somebody presents in a crisis and being blamed for it, it also builds up amongst clinicians about what to expect when someone with BPD comes in. As I said in the beginning, BPD is a spectrum of illness, and the individual experience of the condition is really quite varied. Some people may never encounter hospital settings. For some people, it might be a life-threatening condition. But simply having the diagnosis of BPD in your kind of past medical history when you're encountering a healthcare setting is enough for a clinician to form an opinion of what to expect and to bias them and to use a stigmatized experience in the kind of care that they've been provided. On the flip side as well, I think a lot of clients and patients coming through know that there's going to be some stigma with healthcare and can come in on the defense, in that they're preparing themselves to react to any kind of possibility of a stigmatized experience, any kind of microaggression that a clinician might expect, and that kind of defense and stress that they're holding within themselves, on top of the fact that they often are presenting in a crisis and there's some acute personal stressor going on. It heightens the whole experience, and it can feed back to reinforce the idea that the clinician have that this person is a problem rather than this person has a problem. What we also noticed that was quite interesting is that many people with BPD historically didn't receive their diagnosis from a clinician. They kind of found out by accident. So often it was the case that they would be going through their old medical notes and they would see the diagnosis of BPD associated with their file, or they would kind of look online, find some resources, find the criteria, and be able to self-identify. And there's some evidence to suggest that more recently, clinicians have been looking to avoid the use of the term borderline personality disorder because they're aware of the stigma that it carries, and they're aware that if they give this diagnosis to a person, then wherever they go with that diagnosis in any kind of setting of healthcare, they are likely to experience stigma. Nevertheless, from the client or patient perspective, there's evidence to suggest that actually being able to have the diagnosis is therapeutic. It gives a sense of relief because you now have a structure of an illness which explains all of these behaviors, all of these thought patterns which have been causing problems in your life. And you then can be able to separate all of those patterns and behaviors from your intrinsic sense of self-worth and identity into a mental illness, which is treatable and can be dealt with over a long-term setting. A lot of people reported that it was fantastic to finally have something to explain why they were feeling a certain way, why they were reacting in a certain way, and to know that it wasn't their fault. It was an illness which was kind of pushing them into thinking in certain ways and acting in certain ways. So there's this hard dichotomy of the fact that, yes, it is a very stigmatized illness, and yes, people try to avoid giving the label of BPD, but actually from a client perspective, it can be a helpful thing to have. I also noted that from a lot of the medical documentation, you may have noticed that there were 8 points on the diagnostic criteria for BPD, and that you needed to have at least 5 of them. So there were many people that didn't meet all of the criteria, and they would get the diagnosis of borderline traits. which meant that it wasn't a proper diagnosis of borderline personality disorder. There's also cluster B personality used as well, which is again quite broad sweeping if they didn't fit the criteria. And what that essentially meant is that the client with that borderline traits or cluster B personality, they wouldn't experience the stigma as much in their interactions, but because they didn't have a diagnosis, it would delay them seeking out the targeted therapies because there was no diagnosis to kind of help access those therapies quicker. So again, it's another one of those ideas of, although the stigmatized experience is avoided, actually the care has been delayed because of it. We found across the board that borderline personality disorder was not really understood very well. Historically, the diagnosis came from Sigmund Freud, who examined that there was a group of people who were neither fully psychotic nor neurotic. They kind of existed on the borderline. And unless you are a great practitioner of Freud, that doesn't make sense for a normal average person. And it is the case that the diagnosis has been misconstrued and the ambiguity has been manipulated to just allow the BPD label to be placed on patients that clinicians in the past, and I'm talking kind of 20, 30 years ago, didn't really like. They saw as kind of manipulative or overly emotional and problematic. Whereas nowadays we've got a better understanding of what BPD is, what causes it, and how it comes about and how we can treat it. And that's certainly the case in lots of mental health settings, that we have a better understanding of BPD. But unfortunately in mainstream healthcare, and I can certainly say that on the surgical rotation that I'm currently on, there's still a very poor understanding of what the condition is, how it manifests, and how it can be treated. However, the great thing that we found is that the stigmatized experience and the preconceptions that people have can be overcome. And it's very much through education and through understanding the perspective of the other side. There was a study done on some nurses that they initially, their views on BPD and their experiences were examined. They went through a course which looked at the client perspective and understanding the lived experiences of other people. And when they came through that course, they found that their biases were confronted, and actually they were more willing to look towards working with people with BPD and trying to find some better ways and some better solutions in targeting their therapeutic alliance. So when we put these kind of 6 themes together and when we looked at the data, we found that there was almost like a cycle within the healthcare system. And at each point, the client and the clinician perspectives were coming together, reacting to each other in a negative way, and self-perpetuating this idea of stigma. So if you have a look here, we've conceptualized that initially when a client responds in a heightened period of distress, it reinforces the idea that the clinician has that, they're presenting with a untreatable illness that I can't help them for. The clinician feels powerless. They avoid treating. The client feels powerless because they've been shut out of treatment. The clinician has avoided the learning opportunity to educate themselves on BPD. The client has been unable to get a diagnosis and an explanation of their condition. Both experience a negative interaction from not being able to meet the needs of the other. And in the end, both feel powerless into enacting any therapeutic change or confronting their own experiences about the stigma that they underwent within the healthcare setting, which means that the next time both are in that situation again with another client or clinician, it self-perpetuates, it reinforces the stigmatized interaction, and nothing changes. And that's probably the way it's been for quite a number of years until very recently, when we actually started to delve a bit deeper, to move away from the acute setting and to look at broadly the experiences of BPD, what the condition is, and how we can work towards treating it in a more holistic and patient-focused way. So to conclude, the stigmatized experience goes both ways. We know that certainly there's a lot of stigmatized experience from clients that we know about, and we know that stigma around BPD in healthcare is quite an openly discussed things. But actually, from the data that we've looked at, the mental health professionals as well are having almost a stigmatized experience in the same way, in that they're not utilizing the educational resources to enhance their care, to work through their own preconceptions and to move to a better point of providing therapy. But it's very much the fact that the problem was enclosed by the system, in that the system kind of perpetuated and reinforced the stigmatized experience. And so it's the idea that we need to break out of the system that we have at the moment. We need to encourage education. We need to have more forums like these to really talk about experience and the viewpoints of the other side, so that the two parties can come together to ultimately provide better care for people with BPD. And that's all I have to say. Thank you.
Thank you so much, Daniel, for bringing your research to us today. And it was a great project to do. It really needed to be done. We talked about it at Spectrum as well, about how the stigma appears to come from the mental health clinical community. But not everyone, of course. And sometimes if we imply that when we talk to mental health clinicians, we get quite a pushback on that as well. There's been quite a lot of interesting chat, some endorsements of some of the things you said, and some sort of more nuanced understandings. There's no actual questions. If people want to type a question or a comment into the Q&A box, I'm certainly happy to discuss that right now. We have a few minutes to do that. Thanks for finishing on time, Daniel. I just want to make a couple of observations. One is we did an audit of emergency department at one of our local hospitals here, and we found that people with BPD who come to primary care, to urgent care, often their files are flagged as BPD, and that probably sets up the encounter, perhaps in a negative way. And in fact, an emergency physician came to Spectrum to ask us to audit the department because he felt there was a lot of subtle stigmatisation and under-service that was going on. We looked at that and we compared it with people coming in with similar presentations who had depression but not with personality disorder, because there's quite a lot of suicidal ideation, self-harming behaviours and repeat visits. And we couldn't actually spot any differences in terms of the way things were written up, apart from some language. There was some quite negative language that would be written up in case notes, but that was the only thing, and that was sort of more subtle. In terms of wait times, it was all the same. So that was interesting. The other thing is with diagnosis, receiving diagnosis. I think that people, from what we understand from our clients, the way you get your diagnosis is really important. And we're working with people in old age psychiatry at the moment, and many of them have never been given a diagnosis. All the staff know, oh yes, they have BPD, but they never tell the patient because they feel that there's nothing really to do for somebody who's like 75 and has personality disorder. So the sense that it burns out by the time someone gets older, I think it's actually a mistake to think about it in that way. And there's been some quite good recent publications recently looking at how the symptom expression may change as we age, but the underlying distress is still there. So there's a lot of more conversation that needs to take place so that clinicians feel less powerless, and that people with lived experience are less protective, feeling like they're going to be discriminated against or made to feel bad because people don't know how to manage the distress and give them the help that they're asking for. So I don't want to keep talking because I feel like there's probably some other ones. There is a Q&A and the question has come up. Oh, it disappeared. Hang on. It was very enlightening. Okay, it's a thank you. And there's a question about whether it might be better to give a diagnosis of complex PTSD rather than BPD. I think that's a minefield, because that's something that we're negotiating a bit at the moment as well. Because sometimes there's a small proportion of people with BPD who don't have a trauma background. And so once again, we're discriminating. So my colleagues at Spectrum Psychiatry area, they're quite encouraged by the ICD-11, how it doesn't differentiate and put people into little neat bundles with a type of personality disorder. It's just the general kind of picture. There are some issues along those personality trait lines where people are suffering clinically significant problem that can be helped. So I wonder if we're moving in the right direction just by changing the way we diagnose and the categories that we're going to use. So is there anyone else who would like to volunteer something? There's so much chatting. Maybe Daniel, you can have a look through the chats while we go through the next presentation so you can see the kind of comments that people have made.
Sure.
Some of it's networking, so I'm really glad that people are meeting up with people, and hoping that that will be very fruitful, having conversations after the session's over. But otherwise, I think we'll move to our next speaker.
Gillian,
yes.
There's a question about the effectiveness of clinicians listening to people with lived experience perspectives as part of their training.
Oh, that's just come up. Yes.
But it's often very effective in dispelling negative attitudes.
Daniel, would you like to comment on that? Can you see the comment that's been put into the Q&A?
Oh, yes, yeah. Mention the effectiveness of presupposing. Sorry, I'm just reading it.
Yes.
Great question. So I guess it depends on the type of clinician. I'm not really familiar with, for example, the psychiatric program and the type of lived experience or the clients that they come into and hearing their experiences. In medical school, we had no exposure to people with BPD and their lived experiences, but we did have other people with different illnesses present their lived experience. For example, I think we had a forum where parents of kids with Down syndrome came in and talked about the discrimination that their kids had when they were growing up. So there's definitely opportunities, and I know that students in particular, regardless of the profession that they're going into, are very open to hearing about the experiences of their clients, of their future clients, because it's definitely the case that if you can educate somebody in their formative years, then you're going to have the most impact rather than a very seasoned clinician who's already got very kind of set diagnostic algorithms and ways of thinking about things that are harder to influence. So I think certainly it's a great thing if we can get more lived experience with students, but of course all healthcare professionals in general. And I think it'll lead to better care for all at the end of it.
Okay.
Can I just add, Gillian, that I learned a lot in books at the beginning of my training, and it wasn't until I met people who actually gave personal accounts of their experiences that could translate some meaning into those words. That's when I started to learn. That was the most valuable type of learning. So I agree, Daniel, it's a wonderful added, or it should be part of the curriculum, I think. I'm using the should word, but I really do believe that we're going in that direction.
I agree.
In fact, I think the role of lived experience voices in training, in clinical services and in research around clinical services is becoming more and more the norm now. It's certainly recommended, it's not mandated in most places, but Jo, who just spoke, she's actually helping to develop a panel of lived experience consumers to help inform some of the work and the way that Spectrum presents itself, which I think is really exciting. So thank you, Fern, for that question or observation. That was really helpful. And I think